All right, so 2 hours on a Sunday night of one dude, right? That's rough. So let's figure out how we're going to get through this. And I'm going to start with helping you to understand the lens through which I see things, because how I work and the patients that I see and the way that I've been developed and the way that I've been trained does a lot with how I form my opinions of the literature and how we apply those things. Because there is data science and math that really does run a lot of the world that we see. But how we apply that data in science and math can be really very different from one geography and one culture and one location to another. So I started off in emergency medicine. Even before that, I had finished a graduate degree in neuromolecular biology. And then after starting medical school, I felt like I was never going to use that again. It just seemed to be information that I didn't need for most of the application of what I did. And through emergency medicine training after medical school, again, I didn't realize, because I trained in inner city Philadelphia, so I was really good at the knife and gun club. I was able to do a thoracotomy and sew up a heart or sew up a lung and do these things and not really think twice about it and like eat a sandwich kind of in the middle, whatever. And then all of a sudden, I moved to my first job after Philadelphia to Western Michigan in an emergency department. It was the 10th busiest ER in the country. And it wasn't busy because they had trauma. It was busy because they had misery. And what I found was that every other person that I saw had pain, addiction, suffering, and all of these social conundrums that we have to deal with on a regular basis. And what I found is that what we were doing in medicine, and this is back in 2007 when I started to look at this, what we were doing to them at that point in time was just perpetuating the problem and not fixing it. So we did some pilot work to develop a clinic that, or first just an intervention to develop an understanding of what it was about these patients who were in the emergency department over and over again that kept driving them back. And what I found very quickly is that a large portion of those had a substance use disorder. And I realized also as quickly, I had no training in that. I'd had a total of one lecture in addiction, and that was just an angry anesthesiologist who got caught using fentanyl. It wasn't a matter of, that was it. It was more about a how not to get caught lecture than it was about a treatment lecture. And then my whole training in pain was an hour-long lecture from a different anesthesiologist who told me that basically you just need to give Dilaudid until they don't talk as much. And then you're good. And then you're rock solid. If you go a little farther, you have to give a little Narcan, maybe balance it out. And that was like the whole pain we got, talk we got. But then I realized that it left me completely ill-equipped to take care of these patients who showed up to the emergency department and really complained of suffering. Because it wasn't just pain, like the nerve sending a signal to the brain and causing that pain. And it wasn't just misery of life. It was a combination of those, and we perpetuated that bad situation with people with a genetic risk and got them hooked on medications, whether it be an opioid or a benzodiazepine or the stimulant to keep them awake during the day because of the opioids and the benzodiazepines, and then had nowhere to send them. Nowhere. That we would even tell them, and no training even how to refer them out of the emergency department. And I remember being very frustrated after I did get training in addiction and became board certified in addiction to find out that actually there are a large number of treatment professionals around that are just not available for these patients. And trying to figure out how we take a very disconnected, siloed world and then reconnect it with mainstream medicine without leaving all of the good parts that happened because it developed away from mainstream medicine has been really what I've been working on for the last 5 years. So how many people here are prescribing providers? So somebody who writes a prescription for something. Great. How many are therapists? How many are nurses? Administrators? Executives? I guess since this is the executive meeting. Good. So this is what makes up most of the world, right? And addiction is actually made up of about that ratio at this time in which we have a smaller number of providers that prescribe, medications, whether it be for depression or anxiety or craving abatement or whatever, and a large number of individuals who provide therapy, and then a number of people trying to figure out how to do that with an ever-shrinking dollar. And so as we look at this, we have to figure out how we take that and figure out what that pie needs to look like at the end of the day. How many people do we need to provide medical care? How many people do we need to provide behavioral therapies? How many people do we need to help create an understanding of what is facilitated and utilized 12-step programs? You know, because when I trained in the neuroscience of this and addiction, and that's really what drove me in, more so even than the emergency medicine frustration, was that I finally found a way to apply what I had learned in my graduate school. Because the neuroscience of addiction is actually more well known than almost any other neurobiological disorder. But we don't explain it to our patients, and I think as a field, we maybe haven't fully understood it. So what I want to do is to level set the next piece is I'm going to give you a neuroscience lecture. All right, I hope you had your coffee, right? But the neuroscience lecture that's not so much about the little bitty neurons and exactly what's sitting in there, but the general reason that the patients have, behaviors that we recognize as common. And why these behaviors have gotten them so disconnected from the mainstream medical field to begin with by getting fired from primary care and getting kicked out of emergency departments and not being able to get the help that they need, and why it's so hard to onboard basic treatment within the primary care world, because it's those people. And why it is that understanding the neuroscience can really help us to move forward with why certain treatments are really helpful for a subset as compared to others, and then how we look at the tool shed now, because we have a lot of things that used to be the entire tool shed that are now just a really good tool. How many people have really thought about 12-step in a sense of when is the right time to start it? Based on data. What is the density of utilization based on the data and the population or the brain? Is there a time that you shouldn't use it, that it's actually just wasted time? Is there a time in which if you don't use it, then you've lost that chance? So the answer to this is yes, and what I want to talk through is that plus the medication-assisted treatment and why the theory behind it is valid and why the fears behind it are valid as well, and make sure that we understand that if we do these things in an evidence-based way, in an integrated approach, that we can do it and actually make a margin. So I run a clinic for basically 92% Medicaid patients, and we make a margin. And we have integrated behavioral health, and we have community health workers. We have housing abatement strategies. We have care and case management capability, and I work within a hospital system. So we'll talk a little bit about how that happened as almost kind of an accident of a rock rolling down a hill is what it felt like most of the time. But I still think first it's good for us to understand what we're dealing with from the disease. And everybody in here is an expert at addiction in one way or another. So what I want to do is talk about the three things that we need to survive. You need food, you need water, and you need dopamine. All right, so dopamine is this chemical in the brain that gets you out of bed in the morning when you get up. It's the thing that creates a connection between another human individual. It's this chemical required for motivation. It's what creates a mother-baby bond. And we've studied it enough, thanks to Dr. Elliot Gardner and NIDA, as well as Dr. Abkarian at University of Chicago, and then Brigham and Women's, and a large team of people who've looked at this, not only from an exact amount and what it does in the brain, but we've actually been able to look at this from a functional MRI study, and we've been able to evaluate what the brain looks like in patients who have addiction and are in recovery, and what craving actually looks like in the brain. So if we know that this chemical is released, this dopamine is released at this area called the nucleus accumbens, and I'm going to tell you all these things that my patients know after being in my clinic for 6 months. I love it because they'll go to their primary care doctor for a follow-up once we get them reconnected, and he'll be like, what's wrong? And he's like, well, I just have kind of this anhedonic low dopamine state that's not allowing me to really focus on my, my lateral bed nuclei, my amygdala, because of the, the issues with fear that I have and how and they say that, and I love it because I actually asked them to record it a couple of times just to hear the, sound in the background, that stunned silence. But if we know that this is the case, and we know that dopamine is required, how much dopamine is required? Well, we've tested that, and we know that. So the average amount of dopamine released in a person's brain on a Monday morning when you get up and you get your coffee and you go to work is about 50 nanograms per deciliter. 50. Your worst day, the day you get up, you decide you're not going to go in, you call in and you like fake vomit on the phone so you don't have to go in. You're like, oh, I'm so sick, and you don't even get out of your pajamas. If you're me, you sit in the basement and play Xbox and don't tell anybody. But the day you do nothing, that's about 40 nanograms per deciliter. So what about the best day ever? Won the lottery, 2% body fat, sitting on a beach, right? All that happens like at one moment, like an instantaneous moment. That's about 100 nanograms per deciliter. All right, that's the physiologic max that we're supposed to have. It allows you to actually assess the things around you and make good decisions and risk assess, problems and solve the next, piece of things. It's going to make you not be like naked in the road at 3 o'clock in the morning. So it's good enough to make you happy, but not so happy you start to lose, the pathway of what you're supposed to do the next day. We've even looked at other things like your favorite food. So your favorite food is like 94 nanograms per deciliter. Sex, 92, total bummer. I still think that research needs to be redone. But at the same time, we know that we're supposed to live within this. So what happens when somebody takes something like methamphetamine? Well, it goes to about 1,100 nanograms per deciliter. Heroin in the high 900s, alcohol in the 800s. Marijuana, yes, it's actually addictive. I don't have to preach to that in here, but the reality is it's up in the, the high 5s to low 600s. So this is multiples of what our dopamine level is supposed to be when we utilize this substance. And if you have the genetic predisposition, it's even higher in those patients. So what happens is immediately after that first utilization, the brain doesn't make as much dopamine. It turns it down. It decreases the amount that it releases with each stimuli, which is that chasing the dragon effect. You're never going to have that same feeling of the first time, and you're not going to have that because the body physiologically will not allow it. Ever. Forever, it won't crank it back up to that physiologic maximum. It has changed the kinesin and dynein molecules inside of the cell that move it to that vesicle to the outside and release it. They no longer work like they used to. So over time, if you continue to use, you'll get 1,000, 900, 700, 500, 300, and for the stimulants like cocaine and methamphetamine, which is why they're so hard, they're always going to stimulate above that 100, even after a long time. But for things like heroin, alcohol, benzodiazepines, marijuana, those are things that the body will significantly overcorrect for and actually start to, even when you use them, move that dopamine down to like 70, even if you're using. So in that patient population, let's say we find them, that somebody in primary care actually screened, that somebody asked a basic question. They heard what the NIDA 4 questions were. They heard what a DAST was. And they get them into treatment and we detox them. And so we have them. So when we detox a person and we get everything out of their system, what happens? Now we get a person who's got this really flat affect, hard to concentrate, not really motivated to get up out of the room and get involved in group or do these things. Why is that? It's because they have no dopamine. Their best day ever looks like 20. And their average day is about 14. And on their worst day, it gets below 10. And at 10, physically, you can't get out of bed. You do not have the chemical capability in the central axis of the brain to move. And you will lay there, and you won't even answer. They will give you nothing. So, if we have someone who's not having their dopamine at the level that the body needs it, and remember, we need dopamine in order to survive, because it's what literally gets us out of bed to get food and water, so much so that we've checked what craving looks like in a starvation state, in a dehydration state, and in a drug-free state. So if we look at it and we look in relative terms, and you take a person, you deprive them of water for 3 days, put them in a functional MRI, you have them talk about waterfalls, you play like water sounds in the background, you like sprinkle water on their feet while they're laying in the functional MRI, and you scan their brain, you get the relative size of craving of about a baseball. And this is the density of signal that we see. It lights up on the functional MRI in areas like the medial prefrontal cortex, the anterior cingulate gyrus, the central and lateral bed nuclei of the amygdala. These are areas that light up for craving, and different drugs will light up different areas a little differently. But then we have somebody where we don't eat for 5 days. So 5 days of no food, nothing by mouth, only IV fluids and vitamins. This is what we can do to medical students nowadays when they want $300 a day. And when that happens, we put them in and we ask them beforehand what their favorite food was. And then they go into the functional MRI, and then we bring the food into the room, and we like waft it in there and let them smell it, and we have them talk about it. You let them taste it a little bit, but not swallow it. And then you look at the brain and what that does. So the craving in those areas for that food in a state of basic starvation is about the relative size of a basketball. So higher than that of dehydration. And we think that's only because during dehydration, the body's unable to release as much dopamine, but they're probably equal even if we could hydrate the brain with dehydration of the body. If we look at drug craving, and we have patients who are in recovery 30 days, 60 days, 90 days, 1 year, and 2 years. I'm only going to talk about 1 year and 2 years because there was no difference in craving signal in a brain at 30 days, 60 days, 90 days, or 1 year. So at 1 year for an opioid use disorder, the brain looks the same. For alcohol, it's about 9 to 10 months where that seems to change, but basically it's a year. We put them in the functional MRI and we ask 3 questions. Tell me about the first time that you used. Tell me about the last time that you used. And tell me about the best memory you have using your substance. The signal light up on that was the relative size of a baseball field. This actually, when we did this, we saw almost a complete shutdown of signal intensity in the frontal lobe, the place required for higher level thought. We also saw a shutdown in the areas of the hippocampus, the place required for long-term memory, and the central and lateral bed nuclei of the amygdala, which is part of the emotional brain that we need in order to onboard emotional memory. What is another term for emotional memory? Therapy. So if you're not able to actually onboard therapy right after that, when that dopamine is low, then what are we doing giving a whole lot of therapy to somebody's brain who's not going to be able to actually make physical, emotional changes with that information that we give them? Doesn't make a lot of sense sometimes. So what does that mean? So when we have a low serotonin state in a patient, we replace that serotonin with an SSRI, a selective serotonin reuptake inhibitor. Raises serotonin. Over time, that actually changes some mechanics in the brain. That turns into less depression, less anxiety, depending on which serotonin it works on, which receptor. If we have low dopamine in another part of the brain, for Parkinson's, we just replace dopamine. You know, we tried that. There were a couple of studies where we actually tried to replace dopamine in a person with addiction to see if we could raise it. And one of the problems we ran into was that the part of the brain called the nucleus accumbens is actually a very old part of the brain. And it's highly protected so that it can't be led astray. And so when we try to give it dopamine, in order for us to get enough into the brain for it to do anything, we actually had to significantly increase the dose that we would use for something like Parkinson's to the point where it just caused massive side effects before we ever were able to raise it centrally. So what are some ways, so we looked at what are ways that we can actually get dopamine to raise, can we make it raise? And then we found that there are 2 groups of people, the haves and the have-nots. So if we look at this from a practical stage, we actually can recognize this based on just the trajectory of their disease. So we don't have to have a functional MRI to be able to separate these patients. So remember we talked about how over time the dopamine goes down? Well, the dopamine goes down in a very specific way. First, it releases less. Then it produces less. Then it shrinks the neuron. Then it actually causes the neuron to die through a mechanism of apoptosis. And the ventral tegmental area and the nucleus accumbens, that, the happy part of our brain, the reward system, the limbic system, whichever vernacular you want to use, that part of the brain now has basically had a stroke, because once neurons die, they don't regrow. So for patients who have had utilization since an early age or for a very high utilization rate, meaning a very high dosage rate and density of use rate, those are patients who may have pushed past the little bit of a decrease in release, a little bit of a decrease in size, and may have actually moved to the point of killing those neurons. So if you have a patient who started at 12 to 14 years old, which is the average age my patients started utilizing a controlled substance on a consistent basis, those brains look different at 25 than the person who went to high school, went to college, finished medical school, became a surgeon, and then started utilizing a substance at that point. Because that brain was allowed to develop through adolescence, strengthen the dopamine track, and have resilience. Now that resilience is important because people who have resilience have the ability to naturally reinstate the dopamine level through things like something easy like exercise, family engagement, 12-step modalities. This naturally raises. This is also borne out based on treatment outcomes. If you look at health professional recovery programs for like doctors and pilots and nurses and lawyers, these are people who achieved a lot and then lost a lot. These are people who have a 90% 5-year recovery rate just with an inpatient stay followed by high-intensity outpatient monitoring, 12-step modalities, and then tracking over a period of time up to 5 years. 90%. If we do that same modality for the have-nots, the people that don't have the dopamine axis intact, meaning that they started early, it either shrank or died, what is the retention rate and success rate at the end of 1 year for that group? For the same modality that we use as a standard of care if I needed help. 8%. And that is the meta-analysis Cochrane data evaluating the application of abstinence-based programs specifically for these patients who started early and continued use for a period of time. So what do we do in that group of patients? Well, what we've done is given up. I mean, we've left them out there at this point, and now opioid use disorder, thanks a lot to the iatrogenically caused, prescription writing from doctors, is killing more people for injury-related death in our country than anything else. More than motor vehicle accidents, more than gun deaths. Sadly enough, gun deaths is going to overtake motor vehicle accidents shortly. But a lot of the gun deaths are secondary to what? Drug-related crime. Most of the car accidents are due to what? Driving under the influence. So ultimately, the top 3 injury-related deaths that we see in our country are specifically related to a substance in one way or the other. So what have we found out that we can do for those patients who have either killed that neuron bed or it just shrank and it needs time to grow back? Well, we have indirect ways that we can do that, and those indirect ways include methadone and buprenorphine. So this has been interesting because I came at this into addiction medicine, again, from more of a science standpoint. I myself am not in recovery, and I have friends who are, and I've had these long conversations with them about, I don't know many cardiologists who have an emotional connection to a calcium channel blocker. Or they're only going to write lisinopril. I will not write enalapril. I won't do it. I just don't get that. But in this field, this has been very interesting for me. We actually have a significant emotional reaction to a medication. I have never seen a more negative emotional reaction to a medication than methadone. In the treatment world, in the criminal justice world, and in the familial world of the people who see these, who are family with these patients. This is very interesting to me. We have over 40 years of use with methadone. I think nobody disputes the fact that it has decreased HIV, hepatitis C, drug-related crime for those patients who utilize it. But here's where I think is the rub. In 2 places. One is not necessarily recognizing that we have patients who have 2 different brain diseases. We have one group that has the brain disease of decreased dopamine, that we can naturally raise that up because they didn't do damage. They just irritated it, they decreased the release amount of dopamine, But they have these things that my patients don't. So if I had to go into treatment, I would have disability. I would have a roof. I would have income for that period of time. I would have a family that actually cared about me and helped me and told me I could do it. I would have friends that would actually surround me with support and help to get me back into that. Those are all natural ways to raise dopamine. But what about my patient who had early life trauma, started using at 12 years old, continued to use all the way through, they're now 25, using heroin, cocaine, marijuana, whatever. What about that person when we try to figure out, all right, so you're clean. Where's your natural dopamine going to come from? Because you got 2 felonies, so you can't get a job, you can barely even get a house. Trying to naturally raise that person's dopamine, I would say, is impossible unless you take them and you move them somewhere into an isolated environment for a decade. Because if you put them somewhere for 30, 60, or 90 days, and you put them right back into the environment where they came from, remember, we're looking at a long time before that dopamine comes back. And we know now that detox from alcohol or opioids really is a 6-month phenomenon. It's not a short-term phenomenon. And that the early stuff is the stuff that we recognize, but the longer stuff is mood lability, difficulty sleeping, this, short tempers, all of these things that we see on a consistent basis with our patients. So methadone, if prescribed properly, artificially raises dopamine back up to just the normal level. And how many people have heard from their patients that I just felt normal when I took it? I mean, I hear that every day. Now, that is the difference between, and what we do is we go straight to the methadone clinic that we all remember that did it wrong, right? We go to the clinic that just gave drugs, didn't really give them any therapy, wanted to keep them on it forever. That's not the one I'm talking about. I'm talking about 60% of them that do a really good job with keeping the dose just at the level to actually raise the dopamine. They do directed cognitive behavioral therapy. They get them involved in 12-step modalities. They get them moving forward. They help to build the ecosystem of their life around them. They get them connected with job training and all of these things. That's the model that we're talking about. Well, what about buprenorphine? Still have a pretty emotional reaction from a lot of people about this medication. Studies are pretty clear. Increases healthy baby delivery at 9 months, causes no long-term effects for a pregnant mom, significantly less withdrawal for the baby as compared to methadone in the mother study. Retention and treatment is about 58% as compared to 63% for methadone and about 26% for Vivitrol, the injectable naltrexone. So that kind of retention and treatment for the dopamine have-nots is pretty unprecedented because the retention and treatment for IOP abstinence-based protocols is about 22%. So at its minimum, if used properly, it's a retention tool so that we can really onboard appropriate structural behavioral therapies. The data also shows that what types of therapies we should be adding earlier is more one-on-one cognitive behavioral therapies, dialectical behavioral therapies, in an attempt to basically reparent. Because the first question you should ever ask a patient if you're going to see them is, when was the first time that you started using drugs on a consistent basis? And that is tobacco, alcohol, marijuana, whatever. And they'll say, whatever age, let's say they say 14. So not only does that put them at higher risk for being one of the have-nots, but it also tells you when they stopped emotionally growing. Because at that point, they started chemically coping. So what you have is a 25-year-old, 14-year-old. And what we have to do is just a part of the general approach is to teach them how to have a more emotionally stable approach to things and teach them how to have a more forward-thinking thought process that's thinking not just of right now, but maybe next week, maybe 3 years. And if we catch them early enough using these medications appropriately, and we keep them on them for the right amount of time, and like I say, the studies show 18 months to 2 years is when we start to see changes in the brain consistent with improvement, and we wean them off of those medications. You know, once we start to see that improvement, just like the depression literature that shows that you need 6 to 9 months of stability, at which point you should be trying to wean off the SSRIs or SNRIs. At that point, if they maintain it, then we've attained what we needed without that. But how many docs actually wean them off of their SSRIs? I mean, I have patients that have been on them for a decade and nobody's even rechecked a PHQ-9. I mean, all the time. They walk in and look, I got a bucket of meds. I'm like, are you sad? Well, yeah, it's because I lost my job and I'm on other meds that I maybe am not prescribed for now. But when we look at this, we have to start thinking about, fine. So let's say for a minute that we want to offer all modalities. For the have-nots, for those people, I would say that in the next 2 years, it will basically be malpractice to not offer that. Because we have mortality data that shows a 5 times increase in mortality rate for that group of people if they are offered only an abstinence-based pathway rather than craving abatement medications while we are also onboarding some of these other things. But it comes back to the lens again, and it comes back to this emotional context of these medications. The reason I bring this up is because as addiction medicine moves back into the fold, or actually just into the fold, of direct medical care, which is where really the biggest piece of the pie monetarily lives, we have to understand that we're going to have to do a lot of things in this field that mirror what happens in standard medical care. And if we do that, then we're going to be able to develop appropriate performance measures and outcome measures and tracking for those. But we have to get better at determining who are the haves and have-nots. And we're about 5 years away from just taking a picture of the brain and telling you. We're pretty close. The studies are in secondary validation stage at this point. It's not in the second-tier studies have all shown that we can kind of look at this. And now we need to show that this is the protocol and this is the cutoff and this is the amount. But that, we're 5-6 years away from that at this point. And so if that's the case, then we're going to be able to say have and have-nots. If you could tell if somebody's brain had atrophied the neuron or completely killed it, and the safest way for us to get them stable was buprenorphine, how many people in here would have that same emotional connection? Or would it just seem like the right thing to do because we identified it, we had a picture? And I think part of it is that in addiction medicine, we don't have a picture. What we have is a history, sometimes of our own or sometimes of our friends or some of the data, and then what we try to do is the best we can because we all want the exact same thing. We want a patient who is clean and sober and functional. That's what we want. We want them to recontribute to society and to their own lives. And for this, none of us are on a different page when it comes to that desire for outcome. We've gotten a little bit murky in the how we want to approach it. But if we start to move into the fold, we have to look at what the data, science, and math says. And the data, science, and math is actually relatively clear that we have to start to delineate better which patients we're dealing with. So what does that look like, integrated care? So integrated care in my clinic is just that. We have a team, and each of these teams has a prescriber, a therapist, an MA, a medical assistant, and then there are 2 teams, and we share RN case manager and 2 community health workers. Every morning, those 2 teams run their patients for the day. They talk about who called last night, who's coming in the next day, any referrals that are coming in. 30 minutes in the morning, see patients for the day, on call at night, coordinate everything. So we started taking over entire care of the patient for the first year. Instead of worrying about missed visit at a primary care doctor or some other physician accidentally writing something I didn't want them to, or the patient having a lapse in judgment, which is so early in this where they don't have control because with low dopamine, all that brain is thinking about is dopamine, 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 dopamine. It doesn't have to be the drug even of choice. It's anything that's going to raise dopamine. And that's why we also see a lot of other behaviors in our patients that will make them, seem completely crazy sometimes, just like escalations of behavior in the front of an office that makes sense to us because we see this, but in a primary care office, they're just trying to escalate that behavior to the point where they think they can get something to raise that dopamine. So why is it that on an integrated pathway, when we sit down, how hard is it to do this? And what we found earlier in our development was that the hardest thing to do with a cohesive group is to actually train people to work in a team. Because a team is not the way we're trained, right? We're trained to know what we're doing and how we're doing it, and we're trained to, as a physician at least, be very comfortable that if I'm going to make a decision today that may kill somebody tomorrow. And you have to still wake up and go back to work the next day if you did that. So there requires some ego strength for that. The problem is that ego strength that's required to do the job bleeds over into just blatant ego. And then that blatant ego doesn't allow you to let a master's level therapist tell you what to do. I had a 22-year master's level therapist, Shelley, who's still the lead therapist in my office, and I lucked out because I got somebody who didn't care about that and hierarchy and all that stuff. And so when we sat down and I said, well, this is what I want to do, and she goes, oh my God, let's don't do that. I was like, well, what do you mean? She goes, well, I don't know, maybe if you learn how to ask a question to a patient correctly, you would know that this is a person who lives in a household who has this person here who's going to totally do this. And I was like, oh, yeah, maybe that's right. But then over time, what you learn is that we each have something that we can give each other. She now knows all the neuroscience that I just talked about. She knows the meds that we use and when we use them. But in an integrated fashion, we can have this conversation. So just dropping a therapist in an office does not make that integrated care. It's just co-located care. So what about dropping a patient into here, and we have 20 meds and they show up? What is our scope of practice? It's whatever the patient needs. What we have to look at in addiction medicine is to start owning a lot more than just our addiction piece. Mainly because I think we're actually more well-developed as a specialty that has integrated pathways to do this. So if I sit down with my patient and I'm talking about blood pressure control, but I know their biggest issue is alcohol use disorder that we still haven't gotten a good hold on, I know that writing them another medication to treat their blood pressure is not going to help. I know that when they tell me that they have worsening back pain and they wanted some Neurontin, that they're going to use that to boost. They're not going to use that for their worsening back pain. So being able to write medications in context of the disease is something that we are a specialist of. So how do we pay for it? Because this came up early, and 92% Medicaid, when you start looking at this and you have 92% of your patients on Medicaid, fee-for-service is a dead end. All right, I could fee-for-service, I could see like 100 patients a day, like 3-minute lines, and just walk through, and I'm like, all right, look good, great, here you go. Look good, great, here you go. I could do that all day, and it would still like be a negative margin for that whole team. So what we did is we developed an episodic care payment. So we said, why don't you just pay us once per year, and then we'll see the patient. So we tried to decide how many patients we could see, what the average cost would be, and from that, we developed what that payment was. And it was cheap when we started looking at it, because we could see about 350 new patients a year. And so we charge right at about anywhere from $3,000 to $6,000 for those patients, depending on complication. So we averaged about $4,500, and with that, we actually paid for the clinic. The staff, at least. We weren't paying for all of our stuff, like the administrative cost and the square footage cost and all of that. But we did that as soon as we started looking at, well, what if we added a pay-for-performance piece? What if you paid us a little extra if we decreased ED utilization with them? What if we decreased the number of abnormal toxicological studies, or increased their function through any of the functional studies? What if we decrease their PHQ-9 and we decrease their GAD-7? All of these things that we check. And what if we improve their ASAM criteria? And we now actually can use the ASAM criteria a little bit as an outcome measure, depending on when they come in as compared to where they are. And we've developed a comprehensive complexity index that gives us a level 1 and a level 2 that takes into account medical conditions, social conditions, psychological conditions, including addiction, pain, and marijuana utilization. We're finding marijuana utilization as an independent modifier for a lot of the things that we're working on, and so we even separated that out from just regular substance use disorder. Mainly because of the misinformation that's out there now, and we're having to unravel a lot of stuff that they hear and they come in with, and that spends a lot of time. So at this point, we were finding that with that payment, we were able to actually make about a 2% margin on Medicaid. And then we had a 9-month waiting list. So we couldn't keep up with that, and then we had payers saying, well, I want my patients and this and that, and we're an integrated system, so we have a medical group with about 1,000 employed physicians. We have 13 hospitals and a payer, Priority Health. So Priority Health said, you know what? How about we just pay your FTEs and we send our patients to you? So then all of a sudden we went from a fee-for-service to an episode of care payment model based on complexity to now basically an HMO clinic. But then I said, why be one HMO clinic? And so we went out and got another payer, Molina Medicaid, who also is buying a team and is just going to use that. And so we're doing the same thing with Blue Cross. And so now we're going to have like a multi-HMO clinic where what they own is the access to the team that they need. And with parity, this is huge because what we're going to have is the capability to deliver the care that is now required for them to deliver, for which they don't have the workforce to deliver it. And so instead of you having to capitalize all of your team expenses and know that you're not going to recoup from billing for another 9 months after you start, you got to have that money in the bank and figure out how to capitalize it. Many times, if you just go to the payer and the hospital in your local area and say, we're willing to take your patients and we're willing to let you pay for it, but I need your help and to do this. I have found that in places where I go, like California and Boston and actually in Indiana and down in Texas, that they are absolutely willing to do this in all of these different areas. So the conversation of who we're working with is also something that has to change. So it has to change to who has the most to gain by us doing a good job other than the patient. And that is the payer. That is the person who is on the hook now for the total cost of care because untreated addiction costs a lot of money. Emergency department stays, inpatient stays, ICU admissions, operations, all of these things. So going at it from that pathway has significantly increased our capability to really deliver, integrated care. So how many people here think that they would classify their place as a center of excellence in addiction treatment? Good, so now let's answer the next question, because we have to define what center of excellence means. How many of you have a hepatologist on staff? How many of you identify and treat on-site infectious disease? Excellent. How many of you track 5-year outcomes? How many of you have the full range of care that starts from the identification of the illness and its severity and actually can deliver everything from the inpatient all the way to, in 3.5 years, the touch-up that you're seeing them quarterly with to make sure that they're getting the services that they need when they're ready to deal with some of the stuff they weren't ready to deal with in this part of their life? It's these things wrapped into a package with performance measures and outcome measures and making sure that you're delivering every available evidence-based treatment to patients. And that includes medication-assisted treatment. That includes, naltrexone. That includes buprenorphine. That includes acamprosate. That includes, all of the other medications. How many people here have ever prescribed a medication for craving abatement for marijuana? How many knew there was one? Yeah, N-acetylcysteine. Mucomyst. It's a drug that we've used forever to detoxify Tylenol overdoses. It's now meta-analysis level data showing that it decreases utilization of marijuana by up to 60%. It's now sold by Amazon as a vitamin for $40 for every 3 months worth of dose. And we have good, prospective randomized controlled trial data that this works. The utilization of medication to help with both the abatement of utilization of alcohol like gabapentin, but also will help with the sleep disorder if they're actually not drinking actively. These are medications that are helpful. I mean, if you look at the utilization of the co-occurring disorder treatment and how many have, psychiatry available to them on a regular basis to write medications and monitor those. Great. So this is a gathering of the executive minds within addiction medicine that work out in this world. And there's 15% of people who have these things. So we have to think about what is a center of excellence. Because if you deliver your little piece of pie in a really high fidelity way, that's great. But you are going to segregate yourself out of this gig. Because what the payers want to see, and I meet with them on a regular basis, and what they want to see is someone who can deliver the spectrum of care, who wants to own all of the problems that the patient has, and they will pay top dollar for this. So I sat down with 3 payers and I said, look, I wanted, in my demonstration project for our clinic, which is now just a regularly functioning clinic instead of a demonstration project, how much would you pay knowing what you know now, that we saved you 35% on your total spend on these patients? And the average cost of these patients, because we filtered based on utilization, so those in the ER 10 or more times per year, 2 out of the last 3 years, admitted to the hospital 3 or more times, 2 out of the last 3 years. When we filtered on that, what we found was 85% of those patients, just based on utilization, met for a substance use disorder. And the other 15% had aberrant utilization of a substance, but didn't quite meet for the DSM-5 designation. Almost all of them had a mental health disorder, of major depressive disorder, generalized anxiety disorder, bipolar II disorder was very common when we started drilling down. And then, but a lot of them had inaccurate stuff that was listed in their medical record. They were listed as schizophrenia. No, they were just smoking a crap ton of weed and using coke on the weekends. That's not schizophrenia, but they got that because you know why? Because they got admitted to a psych facility with psychosis, and they had to have a diagnosis before they left in order to get paid. This happens all the time. A patient goes to the emergency department and gets admitted for respiratory depression from an overdose, and they won't put opioid use disorder. They'll put drug-seeking behavior, probably, causing secondary overdose. So even trying to track how many people have addiction in a hospital is hard. We know it's a lot. But how many of you have hospital-based programs that can really help those hospitals deal with this? I mean, most of us don't. So this is ripe because the hospitals are also learning, especially in the accountable care organizations, that if they don't treat addiction and psychiatric comorbidities with very high fidelity and very aggressively, they are going to lose their shirts. So this is actually, I know that it sounded bleak when he was talking earlier about, it's a whole shift and we're all going to lose our shirts and we're all going to be out of a job and all these places are going to close down. I don't think that at all. What I think, if you don't move with what's going on, then yeah, I agree. I think that, you should just hang out and live the last few years of this, but but if you move with this, and you help to integrate into systems of care, and you work with hospital systems, you work with payers, not just in a fee-for-service pathway, because they're going to rake you over the coals for that. It just doesn't work. We know from an advocacy standpoint nationally that we're not getting paid appropriately. We even at ASAM have developed a payer advocacy committee that specifically is there to look at parity implementation at the states and make sure that these, really erroneous prior authorization pathways are taken care of, that these artificial time limits are taken care of, that prior authorizations for inpatient or outpatient treatment are done in an evidence-based way and not just the random Medicaid director's path. But what I have found is that the integrated team also does something really unique. It actually makes this job easier. Because when you have a team approaching this patient and you take care of all the stuff that they need, and if they need a specialty consult, I don't actually send them to the specialist. We have identified 2 gastroenterologists, 2 pulmonologists, 2 cardiologists, 2 orthopedic surgeons that we will take a history and call them on the phone. And they will answer our questions because they don't necessarily want my patient in their office sometimes. Meaning ever. And so when they do that, that enables me to get basically free time, and they're willing to give it because they would rather just me call and say, here's the problem, here's the x-ray, here's the scope, what do you want me to do, than do that. But if we isolate from all of medical care, and you take a person in and you're treating them for addiction, and you haven't checked for hepatitis C and HIV and liver functions, CBCs, bone marrow suppression, neurocognitive evaluation, I don't think we're actually doing the basic requirements of good addiction care at that point. And this is why we have to either have the medical add on a significant amount of behavioral health intervention, or the behavioral health add on a significant amount of medical evaluation so that we can treat this as a combined, integrated team. But that team is not just the 3 people that are there. It absolutely is the patient. And what we have found is that by making the patient the center of that team, which all of us are pretty good at in this field, but literally we don't ever fire patients. And we actually chase them when they don't come back. And so if they don't show up and we know we're going to lose them to retention, we go to their house, we stalk them, we find them. Because we know they need help. You know, this old adage of they just weren't ready, a lot of times means that we didn't have good enough motivational interviewing techniques to make them ready. It means that we didn't give them a reason to want to be ready. Does that mean we get 100%? Oh, goodness, no. But we sure get a lot more than we did before we really did that deep dive. We probably added 30% of retention just by making those basic assumptions that it's our issue that they're not getting better and not all their issue at the beginning. And then you start to onboard the ownership of that disease to them over time. And I think that type of an integrated pattern with that team approach allows you to have a good plan, help them plan, come up with contingency plans for them so that they can go through. Now what about, what's our next steps in this? I mean, this is why you're here. You're trying to figure out what are the next steps, what are the requirements, how do we do it, how do we pay for it, what do our notes need to look like, what do we need to figure out about, oversight. So in medicine, how many people here have a Joint Commission certification? Good, I'd say about a third. So that's like step one, because Joint Commission is not, we haven't given them a lot of tools to help us. We haven't given them a lot of good performance measures or outcome measures or meaningful steps that they should be evaluating. It's not just do you have the oxygen where it needs to be and, are you doing this? To what fidelity are you applying the evidence in addiction medicine, like they would look at if a patient comes into the emergency department with a heart attack and you have 90 minutes to make sure that you get aspirin, that you get, all the, clopidogrel, and that you get them into a heart cath within 90 minutes. Even if you're an outlying hospital, you're still held to that 90 minutes. And if you can't physically do it there, then you better figure out how to fly them to the other hospital. So what about our patients? My patient shows up to the emergency department, they give him Narcan and kick him out. 30-day mortality rate for a non-ST elevation MI or a heart attack is actually lower than the 30-day mortality rate for my recently overdosed patient. Yet if you come in with a small heart attack, they admit you to the hospital, echocardiogram, stress test in the morning, evaluation by cardiology, and all of those things. So why is it that we're not seeing as that same thing when we have a high mortality rate in our patients and they're young? They're in their teens and 20s when they show up as an overdose patient. So these aren't, I've lived a good life, I'm 84 and this is great and grandpa had some chest pain. We admit him, keep him for 3 days and do everything, even if we know that he just coughed a little hard. But at the same time, we don't do any of that for the 22-year-old who we know has a high percentage chance of death in the end of 1 month. So why do we think that is? Stigma. I think we perpetuate stigma. I think we actually have become so exclusive as a specialty. 42 CFR Part 2, you can't see any of my records about my patient. I don't want to tell you anything. I can't even tell you that my patient's being seen, that your patient is being seen at my clinic. We have to have a place that's completely separate from the healthcare system to deliver treatment. We have to deliver this treatment far away from prying eyes. We think we're protecting them from stigma, but I think by having significant amounts of separation from the mainstream treatment of patients, we may actually be perpetuating it. So we have to think about what is required for patient safety and patient quality and patient outcomes for their medical information. Is it something that we have to hold that nobody else can see because we want to hide the fact that they have a chronic neurobiological disorder that we can see on a functional MRI that has a treatment? Because that sounds like something we should all kind of understand and be able to treat. But as a system, we have stigmatized the system enough to where we're not listening to mainstream medicine. We're not integrating as much as we should into mainstream medicine. We're not actually outward facing and telling people what we do and why we do it and how we do it. And it's not just saying we need to treat better at addiction, but you know what? Why don't I put somebody in your hospital for half a day, 5 days a week, and you just pay for their hours, and we'll make sure that they get good treatment and good care. You know, why aren't we taking on more Medicaid patients in a generally privatized cash pay world? I mean, there are answers to these, and they're legitimate answers, like because they'll pay me $4 for something that cost me $400. I mean, just the billing alone many times costs more than what you get reimbursed. But if we know these things and we identify these things and we understand these things, then what we can do is begin to break these down as we talk to these systems. But now is a prime time for us to be able to take very disconnected, siloed systems of care, make them meet this integrated model so that you are having a prescribing clinician working with a behavioral health clinician, working with a case manager so that we know where the patients are, that they're getting the evidence-based care, that we're following up with what we know we're supposed to do for both the haves and the have-nots. And I'm talking again, dopamine haves and have-nots, not money. Because there are people even that have a lot of money that are dopamine have-nots, and they've gone to these, these systems, and then they end up at my clinic because they failed a number of places. And then after 3 months of just being on a medication, they're all of a sudden stable enough to have behavioral therapy applied. But then there are patients who I don't write any meds for because they're haves. They have dopamine. We can make that come back with a little motivational interviewing Tony Robbins session, and they're like, I know I can do this. This is awesome. And you just follow up with them on the phone. Man, you're doing great. And they're like, yeah, I'm going to go to 50 more meetings today. There's like 7 in a row I'm going to go to. Great. That motivation, so when we say the patient has to be ready and motivated to change, what is the key chemical that I discussed is required for motivation? Dopamine. If you don't have dopamine, the one thing that is required for self-help is missing. Motivation. You'll sit there if you're made by the criminal justice system to sit there, but you're not going to get anything out of it. What you're going to hear until you get enough dopamine is wah, 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 wah. So just looking at the context of what we're doing and why we're treating it and using the evidence so that we can figure it out is where we have to start. And then what we say is, you know what? We know more about this disease than we know about almost every other neurobiological disorder. We have treatments that include intensive behavioral therapy, medications, wraparound services. We identify all of the issues with these patients that are secondary to their drinking or their drug use, and we look at the liver, and we look at the kidneys, and we look at the GI system, and we do cognitive testing to see what's happening with that, and we work through all of these things. And then, when we know they're stable and we've identified those, that's when we can hand them back into the mainstream medical care. But we have to get them set up for that. And we have to do what's right, because the primary care docs, no matter how much I train them over and over again, we still miss the tone that you need for these clients or patients. It's not their fault. They didn't wake up one morning. I mean, I'm preaching to the choir at this, here, but at the same time, we know that if we send them out to a general practitioner who's going to write just a script for buprenorphine, they're not exactly getting trauma-informed care with a CBT wraparound, understanding, and sent out with a package of mindfulness along top, and 12-step recovery pathways. They're just getting a script. So it really is up to us to own this so that we can use the medication for good, so that it doesn't turn out to be utilized for what we're seeing in a number of other places for evil. But also be able to say, you know what, you're a person who actually doesn't need that. And be able to be very pragmatic about the application of it and not having yourself pigeonholed as, well, I'm an MAT program. Or I am not an MAT program. We're just addiction treatment programs. We're supposed to just treat a disease. And so I think that as we look at the integrated model, as we start to come together, we know that when I first started this, I didn't use any 12-step. I didn't grow up in it. I didn't understand it. It seemed like pseudoscience to me. I couldn't figure out the literature because the denominator was missing in half the studies, and I didn't know how they chose them. It's frustrating. So we've had it for 70 years, and it's still not even spelled out well for a neuroscientist, and how you apply it. But what I have found after doing this now for a number of years is it wasn't the fact that there was a flaw in the methodology. It's just that when we applied it, it was applied at the wrong time and at the wrong intensity. No different than when I would write a certain drug for a patient. I don't give them Lasix if they're not in congestive heart failure. I don't give them insulin if their blood sugar is normal. If they are ready and they have the ability to start to work the steps because they have stable dopamine, we've identified the plan of action, for recovery, I have found nothing better. And this is something I thought I was just never going to use, to be honest. And what I found is that I don't have anything that I can offer these patients, medication-wise, therapy-wise, or anything, that once we've gotten them stable and in a movement forward in their treatment, that actually allows them to continue to progress in getting their life back and moving it forward and feeling stable. And without it, it makes it really difficult for me to actually wean patients off of these medications. So what that tells me is that the people who say that 12-step works and it works without anything else, you know what? They're right. And the people that say that medication-assisted treatment works and we don't need 12-step, you know what? They're right. If you pick the right patients. But mostly we're both wrong when we start to look in the middle, because the middle of the curve are people that will benefit from both. And figuring out how we pay for that and institutionalize that to the point where it looks like it is connected to the mainstream of healthcare, we actually have the capability to show them how to do better care. Because unlike any other place in medicine that I have seen, addiction treatment already gets the fact that you have to have wraparound services. That it is about your social, world, that it is about your spiritual world, that it is about who you are and what you want to be and why you want to be that. And that's not what they generally do to treat hypertension. That's not what they generally do to treat hypercholesterolemia. So as we start to look at the functional integration of systems and start to try to understand how we take what was, pull everything good from that and move it into what needs to be, we have this amazing opportunity to build the best treatment of any disease out there. So we shouldn't see this as a frustration. This is absolutely a challenge, and it will not be easy, but it is without question the best chance we have to build a complete, start to finish, comprehensive treatment package for patients with addiction, and create a financially viable model to do it within. But we're going to have to move away from things as parity hits. Commercial payers are going to actually start paying appropriate rates, and people are going to know that they have that benefit, so they're going to be less willing to spend cash. I mean, we've already had a number of methadone clinics go out of business when we expanded Medicaid in the state of Michigan because they weren't parred with the payer. And when we expanded Medicaid, patients found out they can get that treatment, paid for by their insurance. And so the cash pay clinics just went out of business, which is fine with me. I'd be happy if I never saw another methadone clinic in my life. And it's not because the drug is bad, but one drug for one patient with one intervention makes no sense. So we're turning all of our methadone clinics into modified medical homes, which will be able to see all of addiction in an outpatient, high-intensity way, just like you would for a methadone clinic, but they'll deliver all medications, whether it's for alcohol, whether it's for opioids, whether it's for marijuana, but also the behavioral therapies and the physical health, because God forbid somebody goes to a clinic to get treatment for addiction and gets a flu shot. These are basic health needs outcomes. We have them captured. They don't want to go to a physician or a nurse practitioner or a PA that doesn't understand the disease. And then with these modified medical homes, we're actually able to start to treat the families of those afflicted with addiction so we can treat them in a way that understands what they have to deal with, to help them prepare for that and get their kids in, Alateen, and make sure that, that if the mom needs help that they get it, or the dad of the mom gets help. And we're able to find out that a number of people in these families also have their own issues that unless we help to stabilize those, there's no way we're going to get our client or patient stable. So comprehensive care with all of these things is really going to be what the future holds, and it's really going to be what it looks like for, how we get to the end of what is going to be a pretty bumpy road over the next few years in the realignment of how we treat this disease in our society, in the standard medical pathway and still outside of the medical pathway. There will always be a niche capability, for cash pay, 90-day, nice programs, but there's a lot of people right now at CMS that are looking to phase out the vast majority of inpatient care because the data is not great. We know that for some patients it's really helpful and the thing they need, but we haven't done a good job in our field of really delineating exactly who that is. We've tried, and I think the ACAM criteria have done an amazing job of helping us to get to that pathway, but even further down the road, we're going to have to start looking at what are the genetic predisposing factors? Where does this person live? Who do they live with? What is the neighborhood they're in? What are the other social issues we're not looking at? So that we can determine, is an inpatient stay what somebody needs or that? So one crowd that we know inpatient stay actually has really good data for is one that hardly gets access. Homeless alcoholics. They have great outcomes from extended inpatient stays, but they have almost no access to beds. So redistributing where we are and how that gets paid for becomes really important. And figuring out what our job is. There are boutique cardiology offices. There are boutique, physicians' offices that just only see a certain crowd and they're only cash pay. And there's always going to be that, but they're less than 1% of the total. But in addiction, it's greater than 50% of the total. And so trying to figure out how we expand access to care to the rest of society without destroying the traditional aspects of addiction that work is going to be difficult because we are going to have to leave some things behind that don't. And we're going to have to integrate some new things that don't feel right at first. And that's going to require a lot of collaboration. It's been interesting. So I'm the chair of the Legislative Action Committee for ASAM. And as I've been in ASAM, I have never realized how much of this there was between societies within the same disease. But I go to the Hill and I try to have a conversation with someone and they're like, what, Doc, I get this, but we've had 5 other national addiction agencies that have come in, and you know what they've said? Something completely different than each other. It's not that there's a group that says one thing and we're sitting here. It's that this person says one thing that suits what they think they need, and this one says this, and this one says this, and this one says this, and then we have drug companies that say something totally different, and we can't coalesce on a message. So right now we have 5 really good bills, in fact 8 really good bills sitting on the Hill that we could manipulate and make really nice and make it work really well for us, but they're sitting there. Because we can't actually come up with an appropriate message as a specialty to get us legislative approval to get our stuff paid for. It's amazing to me, and I see this, and I don't know what it is, and I think a lot of us included, we've had a very narrow message from the beginning, and we should have made that more expansive, which we have. We've had other people who are worried about the old and people that are worried about the new, and then we have hospital-based systems, and then we have the VA hospital that needs money to try to do this, and then we have all of these other groups that want to sell meds to us, do implants for people, and have all of these other long-term treatment pathways, but we can't even coalesce on a message of what works for who. And so if we want to be able to walk into the fold of medicine and be able to be seen equal to or superior to, in many ways, all the other stuff that's done in medicine, we have to start to coalesce on a message. We have to agree to disagree on some aspects, but not let that stop us from having a core message that's pushed forward for patient-centered, client-centered, integrated treatment that significantly improves not only their functional outcome, but society's functional outcome. This is one of the few diseases that destroys a family. This is one of a few diseases that destroys generations in a row. And we have the ability, if we use the evidence base to treat it, to do a good job so that we stop that whole cycle and let that move forward. But without thinking for the future and thinking about the next steps, we're going to lose that opportunity, and we will, like many other specialties within medicine, be told what we're going to do based on regulatory authorities, based on what's going to be happening in DC, and they're going to say, this is what you're going to do. And I'll tell you, after being up there as well, is that that's not really based on evidence. I'm not really sure what it's based on, but I'm still trying to figure that out, because I, even from them, will hear, well, you know what I heard? And I'm like, please tell me who you heard it from, because that's literally not even in our language. I don't know what that means. If we don't do this, then it will be done for us. And so this is the challenge of what you guys have to figure out over the next a whole 3 days, is how do you take the then and now and move it into the future without destroying the ethos of approach, without taking away the core aspects that really do create a stable, happy patient down the road, but then adding in the things that maybe feel uncomfortable. Because I will tell you, the first time that I actually added 12-step recovery programs into what we were doing, it was uncomfortable. I had to go and sit through a lot of meetings and try to figure it out and listen to patients and go to these before I could really explain to a patient why I was sending them there. It's easier for me to say, look at the meta-analysis in the Cochrane database that said this, this, and this. But I don't have that for Medicaid patients. We have it in spades for the people that are haves, the people with dopamine reserve or the capability to naturally do it. We actually have great research. And so when I see the physician patients of mine or the lawyer patients of mine, that is the pathway that we take. I have one of those patients on a med, and it's just oral naltrexone as needed. I don't even look at medications as the first line, because the data shows that why? Because right here we don't need it, but for these other patients it absolutely doesn't. And you know what this has gotten me is kind of legitimacy within the medical staff. So much so that I'm the chief of pain medicine, that I'm also trained in. But and when I come up and I say this is our new alcohol detox pathway in the hospital. Well, here's our new post-operative pain treatment pathway. Here's our new acute on chronic pain treatment pathway. And I just keep handing them these pathways that decrease IV push medications, that decrease prescription lengths of time, that takes away certain prescriptions, that make sure that it's all evidence-based. You know how much pushback I get? Like none. I mean, we have carte blanche on an inpatient hospital setting to make sure that they're doing better care and then referring to the appropriate pathways, because they don't have any help. So we can walk in and actually write the path that we want to put together. So integrating into that system becomes really important, because what we can also write into that pathway is how should we be having our patients evaluated in the hospital, so that when you get a call from a hospital bed for somebody who had acute alcohol detox withdrawal post a knee replacement and they need to come in and get treatment, what do we do? Or the occupational therapy doc that calls you and says, I have this guy who's got an opioid use disorder from his chronic, shoulder pain. I don't know what to do with him. What is the treatment pathway for that? To be able to have that, integrated fully into those systems becomes our spade. That is our ace of spades, is the fact that we have a skill set and a knowledge base about a disease that is just nebulous to most treatment professionals. And so as we start to look at this, the biggest things that we can do is define what our scope of practice is, and I think we need to widen it. Write down how we measure our performance, figure out what our outcomes are, and then come up with a way that we reintegrate stepwise into the medical field and have that paid for. We don't have to play martyrs, because it was funny. I always laughed, and I didn't realize that there were really two separate aspects of addiction medicine, because I work for a health system, so I get a check every 2 weeks, and that's all, and that's what I get. And any speaking fees or whatever just goes back to the hospital. And so when I go there, I took a 26% pay cut from being an emergency medicine doctor to going to addiction medicine, which was interesting, right? Because being an addiction medicine doctor is a crap ton harder than being somebody who treats, emergencies in the ER. That stuff was just pretty straightforward. But sitting down and trying to dig through somebody's trauma and figuring out what it is that we're going to do to get them better, that's hard. I mean, this is really hard work. And I'm not willing for us to be the martyrs in this and to say, we'll do it for whatever you'll pay us. Because this is, I think, one of the most important fields in medicine for the stability of a patient long term, is to be able to take the 20% of society that has one addiction or another, whether that be tobacco use disorder, which ruins orthosurgeries, ruins general surgeries electively, messes up vascular surgeries and causes all this other stuff, to opioid use disorder, which we caused in the medical field for the vast majority of patients, and then figuring out how we own the treatment of pain, or at least the detoxification pathway for those patients who have pain, to help them understand that there is a better way to think about their disease, and to appropriately fit that square peg into the round hole of medicine. And so we're going to have to shave some edges off, and we're going to have to build out areas that we don't normally do. But I think if you think about this from an integrated, point of view, and what would you want if you were sitting here and if you had a family member and you had to put them in a clinic and they're going to stay there for a period of time and they're going to get treatment. When they go there, are they going to check their blood pressure? Are they going to treat that? Are they going to check if they have liver failure? And then if so, get them the appropriate follow-up for that? Are they going to find out that they have hepatitis C and then treat that? Are they going to do that? Because if these are the things that we start to do and onboard into the specialty and widen that scope, then what we're going to have the ability to say is, I don't know what you guys are doing, but this is how we do it. And this is what you have to pay for. And you know what? They'll pay for it. We just have to ask it in the same way, and we have to come up with the same package, and we have to come up with what does a center of excellence look like so that we can say, we have this box checked of center of excellence, and it means this. Because I know that when I said that, everybody in here had a different thought process about what their center of excellence looked like. And trying to figure out what everybody should look like at their base is important. Because if we can do that, then that's what gets you the checkbox at the payer that says, fine, it's worth paying this because we know that the cost offset later is definitely better. I had neck surgery. I had that like 3 years ago, and that cost $50,000. And it was minimally invasive, and they went in with a little camera and a little chisel, and they carved off a bone spur that was growing into my nerve and did a microdiscectomy. Had that on a Wednesday, stayed overnight to a Thursday, was back to work on a Monday. If I would have had a normal fusion or something, then I would have been out for a couple of weeks. I would have had a collar on and not been able to go back to work. But my insurance company, and I called him and I talked to the medical director, and I said, dude, I need this surgery from this guy because I have this specific thing, and I know they're out of network, and I need this. And he did it. So what is that worth to be able to have cervical spine surgery on a Wednesday and be back at work on Monday? That's pretty awesome. And if we put together efficient, effective treatment pathways for addiction, then what we do is we can take these people, have them spend that $50,000 because they know that they're going to be happy and get right back to where they need to go. Because I know of very few orthopedic surgeries other than trauma repair that actually cause as much improvement in a person's function than treating disease. And so we need to figure out how we become the integrated orthopedic surgery of the future, because the pie in medicine is not getting bigger, just the allocation of each of those pieces. And so we have to figure out how we reallocate our piece of pie based on our doing more than just a little narrow piece of addiction treatment. And if we do that, then we're going to be able to coalesce on appropriate payment modalities, team-based care, integrated approaches, high-fidelity application of education so that we can have workforce development all the way from a prescribing physician, all the way to a community health worker, and the family that surrounds the patient. And if we can have that high-fidelity workforce development information given, and we know that it's evidence-based, then we know what they're doing, we know what they're learning, and then we can help to reinforce that as we see them and teach them. These are the competencies that we need as a field to develop. I think I would like to answer specific questions, if there are any, for the rest of this, and that can be about really anything that we talked about. I've done this long enough that I don't really need the PowerPoint, so this is just kind of what I do for a living, is treat these patients and build these systems of care. And so I'm happy to answer questions. I'm unfortunately not going to be able to be here the next couple of days, but I'd be happy to answer if I can. Yeah. Yeah, so the question is that I mentioned at 18 to 24 months that we start to wean them off, and what does that mean for dopamine levels and receptors? So In the nucleus accumbens, it's more about the release of dopamine and the size of the neuron than it is about the receptors for the dopamine, because those don't, in that part of the brain, seem to get as downregulated as quickly as does the release of dopamine. But at that 18 months, what we find is a resurgence of the ability to release it, capture it, and use it, both from this area called the ventral tegmental area, the shell of the nucleus accumbens, and the core. And those are three distinct different places, but the dopamine release in all of those does seem to get better. Now, if at 18 months we start to wean a patient, because at 18 months is when we start talking about it. And the way that we wean a patient is, hey, I think you're doing really good. You don't meet the DSM-5 criteria for addiction anymore. You have a job, you have stable housing, we've handled your Maslow's hierarchy bottom rung, so we know that we're good. What do you think about decreasing these meds? I'm not going to do it today, but just tell me about that. That tells me a lot about where they are in their recovery at that point. And if they look at me with a panic-stricken face because I'm going to decrease their meds, at that point we intensify their behavioral therapy again and then see if we're missing something from that side. But then we just wait and then we try it again, because what we have to discern is between the person whose neuron is actually dead and the person whose neuron is just shrunk. Because I'll find some patients that I can bounce back in 3 to 5 months of buprenorphine because they were the one that had just decreased the amount. And I'll have them on 2 milligrams of buprenorphine, like a really, a little tiny dose, and they feel normal with just that tiny dose. And that tiny dose allows me to know, oh, we're not going to have to be on this too long because they already have a baseline dopamine that was good. They have a good response to this, so I know that the receptors are working great. And then that. So in my brain, what I see is an equalizer of their brain. When I add this, I see the D2 receptor getting heightened up and the dopamine release happening. And then I see serotonin buffeting with that so that they can have more of that fear response and the lateral bed nuclei of the amygdala decreased. But you have to measure timing with behavior, and so testing those waters is important. Having a strict weaning phase actually significantly increases relapse. But what's happening chemically is that patient, you're determining whether or not that patient is actually reconstituting those neurons or not. And that's what it helps you to understand. Now, some it takes up to 2 years, and that's just a reality. But a lot of these you can get taken care of within about 18 months and start the wean and be done weaning by 2 years. That doesn't mean that if things come back and they have a huge problem in their life and we haven't gotten all the coping skills stuff taken care of, that we may need to temporarily put them back on the med at a low dose. But we have to continue to watch them throughout that time. But you definitely have to be able to onboard the behavioral therapies and the coping skills with that. Yeah, there were 2 studies. Yeah, so there were 2 studies, and it was one done in Hawaii and actually one done in Alabama. Do you want to know the funny part? It was law enforcement that did it. So these were people who were mandated through the criminal justice system to mirror the exact treatment pathway that we did. And so they did it 2 ways. The first way was just they did this contingency management strategy where they said that if you drop dirty, you immediately go to jail for 1 to 2 days. And that's a pretty well-known study. And we all utilize that as, hey, that's great. That means immediate feedback is much more effective. But what they followed that up with are studies where they actually gave the same thing that they were given to the, quote, financial haves, because that's how they saw it. They didn't look at it from a dopamine standpoint. And they put them into that same pathway within their drug court system for basically a year, and they mandated them to the same thing. And right, but those places actually freak my patients out. I mean, if you put them in like a quiet place and make them do yoga, they're going to shoot themselves. So, I mean, these are patients who this is not okay for them. So we have to say what same is. So culturally speaking, that is not where they're comfortable. My patients don't want to be there. That honestly makes them very uncomfortable to be in that type of an environment because they've grown up in chaos and they've grown up in this. And so when we say we've applied the same treatment to the same group, if we applied the same treatment in a culturally appropriate, connected way, meaning a place that they felt comfortable in, which is not going to be Talbot's, it's not going to be, in Palm Springs, it's not going to be these very beautiful places that when I come here and I go to the spa and I get to hang out, I can find myself a little bit. I can have some introspection and I can start to think. That's not what makes them have introspection. It makes them feel disconnected and scared when you talk to them. So no, they weren't at the exact same ones, but they delivered the same stuff. They did daily 12 steps. They were in it for 90 days. And then they had IOP on the way out, and they tracked them for a year. It's about as good as it's ever going to get for that subset of patients because you're only going to be able to pay for that. And so when we looked at the best we could do for equivalency, in reality, 8%, not 20, 8% were the ones that were doing good at a year. So it's not even close. I mean, it's not even close at all. But you take that same group and you put them in a methadone clinic for opioid use disorder and you have 63% retention. And then at 1 year, you have clean urines. And those studies have been done over and over again, sitting in the Cochrane database, multiple meta-analysis, and that. So that's where I get stuck, is I have a mountain of literature that backs up the other one. And it makes it really difficult, because I work as a payer, too. I'm the medical director for our regional CMH, so I have to decide how we spend a very tiny amount of money on Medicaid. So I have $1.72 per day per patient in our 7-county region that we take care of patients. I mean, that doesn't get, yoga on the beach, man. It doesn't. What it gets is, I'm lucky if it gets them into any treatment that's worth it, because when the door closes, I don't even know what's happening when the door closes. Right, but you're never going to be able to test a cohort of MEs against a cohort of Medicaid patients. I mean, that's just because it's actually probably apples to oranges to start. Because I do think, like I stated, it's a different brain disease. Because you add early life trauma, and we know how early life trauma actually messes with the neuroaxis. And the part of the neuroaxis it messes with is actually one of the same parts that make people more susceptible to substance use disorders, because it actually hypertrophies the lateral bed nuclei of the amygdala, which makes them have a higher fear response, which is significantly decreased with a substance, and typically opioids and alcohol. So these are things, and they may already have a dopamine depletion through early life trauma as well from some of the same mechanisms. So that's why I say that we really need to look at this as two different brain diseases, being one in which we have a pretty good treatment pathway. It works really well for a lot of people, better than hypertension and hypercholesterolemia treatment. But if we apply that same to somebody with a different brain disease, then it's just not going to work as well. And the best we could do is look at it, and we haven't been able to find equivalent data, or even close. I mean, it was like factors of difference. Yeah, so we see this all the time, and this is a conversation that happens a lot in the world of people who write for buprenorphine. So much so that there's a company developing a 2 milligram, or actually a 0.5 to 1.5 milligram dose of buprenorphine for anhedonic depression. And so what we're finding is that for these patients who have this medication for an extended period of time and can't get off, they are probably low dopamine either at baseline, or they have injured that neuronal axis to the point where they just require a little bit of this medication to make them feel normal. Because when they talk about withdrawal, they're talking about the panicky feeling of withdrawal, because they don't ever measure out in the cows very well. Like when you're looking at the clinical opioid withdrawal scale, they're measured very low or none when it comes to the physiologic symptoms. Some will, but most won't. And so when we look at that, there's probably just a baseline low dopamine state. And then when you have a baseline low dopamine state, your serotonin sometimes can compensate. And what you almost get is an innate serotonin syndrome, which feels a lot like withdrawal. And so this is all just theory at this point, but there are a couple of theoretical papers written by some neuroscientists that are pretty interesting on this subject. And so the question is if we get them down to 2 milligrams a day, I have people who will take a 2 milligram strip and like cut it into quarters, and like they just can't get off that last little piece. For half of those patients, we got them off and put them on Vivitrol, naltrexone, injectable, to see if we could actually kind of force the opioid system to rebound. Because when you do that, when you block the opioid system completely, then it's forced to compensate for being blocked. And in those patients, we actually had abatement of those symptoms with that medication. That is anecdotal and not published anywhere, but I'm just saying that we're trying to deal with this too. And but for the other ones, man, they were really functional. They were doing everything with their family. Their urines were completely clean. Even when we had, they would come in random drops and like all this stuff, and they're doing great. So I started to ask myself the question of, why am I so worried about it? I mean, we put patients on antipsychotics for sleep for years and not think twice about it. But why am I worried about 2 milligrams of buprenorphine? And then I started to recognize that even I was having some of these emotional attachments to being completely off of drugs before I would say they were being clean or sober. I think we really have to examine that. And I think we have to think about it, because our ideas of what we call clean and sober are based on 70 years of history of what we called it, but we didn't have the neuroscience understanding. We didn't have the capability to assess stability. We didn't have the capability to assess function, to look at the differences between this brain disease and that brain disease. So I think it's worth the conversation to think about, if it's such a catastrophe for that patient to get off of 2 milligrams because it changes the brain chemistry enough for them to think about using again, maybe we shouldn't. It's a hard question to answer. We have some patients, probably 15% of patients, that don't rebound that dopamine and require long-term medication-assisted treatment to maintain that. And if their function is improved and their coping capabilities are improved and their interaction is improved, I'm not sure what we gain by actually getting them completely off past that. Nobody's been able to answer that for me, other than just being able to say that I'm off of a medication. But if you can't maintain the same level of function off, then I start to worry that maybe we're doing it for reasons that are our own issue. One of the things that we have to look at is, if I'm a cardiologist and I do stents, and I use bare metal stents, then literature comes out that says I need to use a drug-eluting stent. They just switch to the drug-eluting stent. You know, if it says that you're not supposed to cath at this point, then they don't do a heart cath anymore. I think that we need to get to the point where we can coalesce on the treatment is the treatment is the treatment, and it's what the data says. And while some people need a stent, some people don't. If some people need a bare metal stent, then other people need a drug-eluting stent. And just make it very pragmatic in that sense, and take away a lot of our own emotion and deal with this more, Spock-like in that sense of, here's what the data says. Now, how you apply it can absolutely, and has to be for this disease process, full of emotion and full of appropriate empathy in the approach in which you sit down and have a conversation with that patient. But the way in which we decide the treatment path should just be really based on the data science and math. I think you need to, so we do this as well because we don't have an IOP attached to what we do. My hospital system didn't really even understand what IOP meant when I tried to explain it to them. And so we just reached out to somebody who already had a very successful, appropriate intensive outpatient treatment, and we have them directly connected to us, and they're on the phone with us when we run our morning meetings so that we can talk about our patients in common. We also don't have inpatient treatment, and so we have a direct connection with an inpatient facility that will take our patients if we feel they meet that criteria, especially our co-occurring patients if they need stabilization on an inpatient side. So there are many of those pieces that we don't own. And I think that you shouldn't expect to own that. So when I talked about ownership, I'm doing it in the modern sense of you can talk to somebody on right in front of you on an iPad. And so you need to be able to have the continuum of care, if not under the same ceiling, in a flawless, connected way. Not in a referral, eval and treat way, but in a we're all connected by contract to see each other's patients, to help each other's out, and you set up the workflow so that you can actually interact with them on a regular basis and not worry about the different pathways of treatment. Well, we have a health information exchange in Michigan that's actually pretty robust, and so we can go in and look at all of laboratory studies and every inpatient admissions and this and that. Because of 42 CFR, we required a secondary, for Part 2, we required a secondary DUA, data use agreement. And so we just, basically had a data use agreement, filled out so that we knew how we were going to use it, and then patients signed the release of information as our normal intake for all of these facilities. At ASAM, we're embarking on a goal to build a large coalition, well-funded, for this big push over the next 1 year to really move things forward. And I think that message is not going to be what our message is. It's going to be informed by whoever's at the table. Because we're not going to agree on everything. And so what we have to determine are what are the most important messages that we need legislatively placed. And is that payment reform? Is it prevention? Is it paying for an integrated payment model in a way in which we know that it does? Is it tax abatement for starting up a new that? Is it EMR support so that we can get money from the federal government to expand the EMR just like in the medical health world? Is it medication-assisted treatment, raising the cap on buprenorphine? Is it, making sure that we have a set of performance measures and outcome measures that we all agree on, that we want to measure our success with? Is it helping to develop value-based purchasing programs that are funded initially with CMS money so that we can build those out and test them? I mean, it's the whole thing. And so I know what I would have it look like, but at the same time, that doesn't mean it's my lens. And so we're putting together a team so that we can get all of the lenses through which we see this and then really develop what is a cohesive, common vernacular push for comprehensive, patient, client-focused care that centers on how we get the best functional outcomes. And whichever little pieces, which is really all of those pieces that I added plus a whole bunch more, have to be put in there, but we have to agree on staging and which is the right place to say it. We got to make sure that we're not stepping on each other's toes because we each have things we need. So I'm board certified in addiction medicine, and I have a 100 patient limit on buprenorphine, and I sit in the mid-90s all the time, and I had to put a stop to seeing patients. Yet I have a family doctor down the road who took an 8-hour course and has the same 96 patients. That's weird. That really makes no sense to me, yet we have people pushing back harder than I have ever seen at raising the limit for board-certified docs. I have a hard time understanding that. I mean, I get the theory and the fear-mongering aspect of the pill mills and the stuff like that, and I think we have to hyper-regulate the industry from that standpoint. You know, from anybody writing a controlled substance to someone who has an addiction to a controlled substance, that needs to be appropriately and really stringently regulated. But I'm stuck. I have to turn away pregnant patients. I mean, they come in and they're like, I want help. And I'm like, I can't help you. I have to send you down the road. And then, or down another road and another road and another road. And that's just, it's horrible. And then that puts a lot of prescribers in a bad place because they end up getting on the slippery slope of, I know this patient needs help, so I'll just call it pain. And I'll write it. And now they're breaking a federal law to try to help the patient. That's just a bad position. So it's those things that we need to identify that just seem logical. Like, I don't think it should just be written willy-nilly. We should have had limits on oxy, and we wouldn't be in this predicament that we started. So it's not like we should just have buckets of buprenorphine. But, you know, so from a prescriber standpoint, that's important for me to be able to have access for my patients to come and see me. But that's not going to be the thing that's most important to the behavioral therapist. You know, and we need to figure out what is the most important piece to the behavioral therapist. Is it being able to bill appropriately for groups? Is it being able to bill for a facilitated 12-step? Is it being able to have status to have the capability to run a program as long as you're connected to a prescribing, you know, a prescriber to help you with the medication-assisted recovery piece? You know, those are the things that we would have to sit down. But until we all sit down at the same table, that we agree that there are certain aspects that certain people know better than we do. You know, my therapist doesn't let me do therapy because I'm terrible at it. She's told me, she's like, you know, after I told my chronically anxious patient that she should just figure out the 10 most anxious things that she knows and come up with a good plan for each of them, I was told I can no longer do therapy. And that's a really smart decision my therapist made. But she's going to have ideas of what we need to do to build the system better that are different than mine because her lens and her knowledge and her background is completely different. And that's why I think it's important that as we build this table of people around it, that it's not just a bunch of me's who are going to echo me. That I have, you know, what I think and they have what they think, and we really, truly coalesce on a message that encompasses all aspects of treatment, and whether that be, you know, long-term residential capability for those that need it, and making sure that we don't completely throw the baby out with the bathwater. You know, but doing that in a pragmatic way instead of somebody who has the dollar on the line going to DC and fending for themselves. They should be able to have somebody like me who has no ties to any inpatient thing to be able to fend for them. And then I should know that this person in the coalition who has never written buprenorphine in their life says, you know, what's frustrating for me is that I can't get my patients into a prescriber to help them with, you know, with the medication they need. I mean, if we did that, that completely changes the tone and the pathway on the Hill, completely. Because then Burwell will get the same message from different people, which makes it easy for them to make changes. But right now it's hard because we got this person doing this and saying this. And so that message has to be a coalition message and not a single entity message. Our health professional recovery program in Michigan helps me make that sometimes by not allowing them to be on agonist therapy. But whether or not we decide to utilize this has to do with the age of onset of use and how severely afflicted they are by the disease. So we use a combination of the ASAM criteria and ASI, Addiction Severity Index, and the DSM-5 criteria. And if they're severe in the DSM-5 criteria and they have all this early life trauma and we know that they're going to go home to a very dysfunctional area, then that's a no-brainer for me for medication. If I'm on the fence and I don't know, I ask the patient. And then I just start them at a tiny dose. And then we see them, 2 or 3 times in the first week and a couple times the next week. We follow them very closely. And then if we find that the behavior hasn't changed with the medication, then the medication is probably not the right way, and then we just need to highly intensify the behavioral therapy and move to that. We don't have a blood test or a brain scan yet to really determine it, so the best is on-the-job training, and it takes a little while. But it's something that now I think we're about to be able to put out some good guidance for how you would start to delineate the difference between the two. Because if I have a doctor who's wicked rich, but he's using heroin and he's been just popping oxy since he was 22 and just like he's like a brilliant person, so he was able to get through all the way, he's still a have-not. I mean, his brain's still messed up, and he's probably not going to get better unless I put him on a stabilizing medication to stabilize that dopamine. And in the way that we have it set up now, we would just let them fail and lose their license and their capability to maintain their life just because that's what we say. So looking at the person and how they've used and the time in which they use and the density with which they've used and how discordant their current life is how we make that decision. My hope is that we can coalesce that down into a 15-minute questionnaire at some point or a brain scan. But right now we have a 3-hour intake, and that's a lot. And I think a lot of us have a pretty hefty intake, especially on the inpatient side. But for us in the outpatient, 3 hours of time for the physician, the case manager, and the therapist to see them and get all the information is a lot of time. Well, Benzos are a little tougher because, if they've been on Benzos for a long time, you can't just stop them. So what we do is, and pretty much what the standard protocol is, you flip them to a longer-acting benzo and wean them slowly over 6 months so that you don't have any risks of the breakthrough, and then you treat them adequately for their anxiety and do that. For alcohol, I offer everybody at minimum naltrexone because the data is just too good to not do that, especially early in treatment. And I have some of my physicians that will put on oral naltrexone, and I have some that we've given shots to. That medication is really helpful for those patients who already have enough dopamine to kind of make it through the day. Because they say highly motivated, the literature says highly motivated people are really good candidates for this, and what do you need for motivation? Dopamine, so that means they're a dopamine have, and this is a person who will do good with blocking their opioid system most of the time. But we're still not at the point where we can be perfect with that. Yeah, absolutely. And so we've actually set up NA and 12-step groups for those on medication so that everybody in the room is on a medication and they can have the conversation amongst themselves and they can't be made to feel guilty for getting treatment. Because, that's a huge problem. When I have somebody telling my patient with legit schizophrenia to stop taking their antipsychotic because they're otherwise not clean, that's just, I can't take that. That's practicing medicine without a license, and that's actually not okay. That's illegal. It's a felony. And so it's a felony for a reason. And so we have to start bridging that gap between there being a absolutism about any of this. Not absolutely everybody should be thought about as someone who could use medication, but that doesn't mean that absolutely everybody needs it. Absolutely everybody should be thought of as somebody who could use the abstinence-based pathway, but absolutely not everybody is going to need that pathway. Whichever pathway is chosen and is working to increase the function, and I think we have to get away from clean and just move to function. That's what we do in other diseases. Clean is, what I have found in my patients that have been in other programs before they came to ours is they'll have a dirty urine and we treat it like a catastrophic failure of life, instead of just a normal progression of a chronic neurobiological disorder who had to slip up on a weekend because their friend died and they happened to be in a place where they were just knee-deep in drugs and they used, but they come back and it's like we got to start over, like, give me your chip back. It just feels weird, from somebody who hasn't been through it. And so maybe I've lost perspective or don't have the perspective, but at the same time, if me as a board-certified treatment professional can't gain that perspective, I think we have to start questioning whether that is the perspective we should be taking. And so I think we lose clean or dirty or that, and we just start talking about how well is your life functioning? How are you doing? And if they meet functional goals and they're maintaining their status as a family member and they're working and they're a good father to their children or a good mother to their children and a good member of that family and of that society, then I don't know if we can ask for more than that. Because perfection, I'm pretty sure that we don't start kicking our diabetics who ate a Krispy Kreme. When they're down. We don't jail them for sure, and we don't take away their kids like CPS would for a dirty urine. So these are These are all things that I think we need to coalesce on. Like I said, we need to coalesce on what we're working toward. And I would say that the data is pretty solid that we should be working toward function, not perfection. Yeah, so sober living facilities are one of the most valuable things that we have to get our patients into, especially those with unstable housing or in and out of shelters or things like that, and even those that are just in a non-supportive home. I mean, I had a patient who was in a beautiful marble 5,000 square foot, $1 million home with a family and kids, but his wife was just mean. I mean, she was just really mean to him about these things. And I'm sure that there was obvious history with this, but we couldn't find any domestic violence or anything, even when we questioned kids and talked to the wife or anything. So I took him out of that situation and just put him in a sober living facility, and within 3 months, the guy was just like totally better. And he was around mostly people who were previously homeless, and this guy was a stockbroker. I mean, so sober living is not just for those disparate people. I think if we used it more and integrated it more into the normal treatment pathway, that we would absolutely have better outcomes. And I think it's also a step-down unit for inpatient, like long-term treatment for patients as well. For sure. We have 3 of those in Grand Rapids, and mainly I can do that because I'm the medical director of the region. And I can say, we're not going to pay you unless you allow for medication-assisted treatment, and you can decide whether or not you want to see our patients. And then they said, well, since you're the only people who pay us, then we'll do it. And what they've done is we just explained very specifically that everybody has the right to be evaluated for medication, but not everybody needs it. And if you're somebody who doesn't need it and you're doing well, then it's no big deal. And if you're somebody who needed it and you're doing well, then it's great. But it's about the learning process as well, and I think that also breaks down some of the barriers. At first, it caused some angst, but after a while, it just was what it was, and people did well. Does group therapy need to change? No. When we utilize it, yes. So group therapy works really well when we train a patient how to behave in a group. When we train somebody in specific individualized cognitive behavioral therapy, and then everybody in that group is trained in those basic techniques, and then you have a facilitated group pathway that then can grow to a self-help group, so that it doesn't just turn into war stories. Because then that becomes eclectic therapy and not really focused, appropriate group therapy. And I think that if we state, look, it's not the group therapy problem, because group therapy has a wonderful role to play. It actually is very stabilizing for a large number of people, especially in that validation pathway of, they're not alone, and these are other people that have to deal with this, and these are tricks that they've figured out and learned, as long as it's not like tricks to pass a drugs test or things like that. But in the group therapies, I see we have to make sure and reframe that appropriately, or yes, they will go by the wayside. But group therapy is just as important as individualized therapy. I think it's just about when we start to utilize it. That's also very important. If you think about Maslow's hierarchy of needs, self-actualization, which is actually the same as spirituality, are at the top of that. And so if you really want somebody to feel self-actualized or really have the so-called spiritual awakening within a 12-step program, they have to have the capability to do so. And if they don't have stable housing and they don't have food and they're not in that, they're just not going to have it. They'll show up and they may find some stability from being around those people around them, but they can get that in a CBT group or just showing up to the clinic. So if we really want it to work for what it was supposed to, you have to get somebody whose dopamine has gotten to the point where they can understand what they're doing, but also handle a lot of those lower rungs of the Maslow's hierarchy in order for them to have that capability to have some self-actualization, or spirituality, or however you want to, capture that in a word, but for them to be able to do it. So we wait for a year before we start introducing it. We ask everybody at the very beginning if they've ever been involved in it, and if so, was it helpful for them? And if their answer is yes, then we get them involved immediately. But so some people we get started right away, especially if they've had a history, and that was the time. A lot of our patients would be, that's when I was most stable, is when I had a sponsor and I was working the steps and I was going through this. So we get them immediately in it, knowing that they've already been there, so it's not going to be as cloudy for them because they've already gotten the basis of it and the basic understanding. But a year for those that are new to it. Yeah, so we've done both. And the first conversation that I had was, can you tell me how much addiction is costing you? They had no idea. And the funny thing is they can't get any idea from their data because nobody codes it. So it's an invisible disease in their data set. So you have to let them know that 37 million people in the United States have an addictive disorder. You have to let them know that, for a patient who has an unstable alcohol use disorder, you're never going to get them to have stable hypertension or stable hypercholesterolemia, or show up for their visits. You're going to have increased GI bleed risk. You're going to have increased risk of hospitalization as compared to someone who you have stable on that, who's going to be compliant with their medications. So you have to introduce to them the concept that a lot of their underlying cost comes from addiction. And they're going to want to call it other things: non-compliance, drug-seeking behavior. It's addiction. And when you just explain it in that way, that kind of flips the switch for a lot of them, and like, all right, well, let's see what we can do. And then they start looking for proxies for addiction in their data set. High liver function tests, positive urine drug screens, drug-seeking behavior diagnoses out of an emergency department, or just utilization. So once they start looking for the proxies for that, then they do find that they have a very large number of people who need treatment that they don't have a place to send them. Because usually in that setting, the carve-out is taken care of it for those patients that they see as the normal, quote, addiction patients. A lot of our patients are, in general in addiction, are late bloomers. So if you have an inpatient facility, you don't get them until they get caught. But at the same time, mine present all the time into that. So, but the conversation is, there is a parity law that says you have to be able to have access to the treatment for these patients no differently than, cardiology. So where do you send them? And make them answer the question. You say, did you know that we're right here and we do this and we can deliver, completely comprehensive care for these patients? It'll decrease your overall cost. And the good thing is, there's actually good, data out there that shows, those data are pretty clear that appropriate treatment of addiction decreases utilization, decreases total cost of care. And so I would start with the data science and math, but really sometimes just enlightening them as to the density of disease within their population. Well, the testings that you have to do are the things that are associated very closely with addiction. And so that comprehensive service, the things that are chronic gastritis. They're going to have an increased risk of Barrett's esophagitis, which means that they're going to have an increased risk of gastric cancer, which is why alcoholics have an increased risk of gastric cancer. So it's just a worsening of something that they're going to have to pay for down the road. So getting them an upper GI. So ordering an upper GI, screening for Hep C, HIV, sexually transmitted diseases, that should just be the normal intake process for an addiction patient. And because those high-risk behaviors, in people who may just, be an alcoholic and not injecting heroin, they still have a lot of high-risk behaviors outside of the home that puts them at risk for a lot of these sexually transmitted infections and things like that. So making sure you check all of those as a piece. And then that comprehensive care approach is something that the payers also really like, because you're not just dealing with you as a little narrow specialty, and then you're starting to creep into the other places of screening for high risk and high cost diseases, and then getting them hooked up with the appropriate treatment. Well, I think a part of it is figuring out that it's all treatment. And whether it's with a medication or with behavioral therapy or both, it's still just the standardized treatment. And so what we've had to do is educate everybody with the data. And I've sat down and I had conversations with people that I said, we're not going to pay you for your services unless you've connected with somebody who can evaluate your clients for the possibility of delivering medication. Period. And so you go after the people that actually have the carrot that they need after you've gone to them and said, look, what is it about this that drives you nuts? And they give you theory and and stuff that's like feeling and emotion. It's not data and science. And then you just say, but what about this? It says right here that it decreases mortality rate by 30%. You don't want to decrease mortality rate by 30%? Yeah, but the data is very clear that the Suboxone percentage on the streets is directly related to lack of care. So the places that you find the highest amount of Suboxone on the streets are the places that have the lowest access to care. The more you increase access to appropriate treatment, the less you see of that on the streets. And methadone is not coming from addiction. Methadone is coming from people who write that prescription for pain. So, but you just have to know the answers to this is stuff, believe me, I've had those same questions asked 1,000 times, so I've had to develop answers. And so we're trying to put together kind of a frequently asked questions thing. Testing, like, your local hospital. Our local hospital would do urine drug screening on only a small percentage of our pregnant patients, and I tried to get them to institute universal screening for all of them, for every patient that showed up pregnant, regardless of socioeconomic status or whatever, or which doctor they were seeing, that everybody would get a night of 4 and a deeper dive evaluation with an assist or a DAST if they were positive on the night of 4, and a toxicological screen. Because those that have significant addiction are just going to lie on the screening. You know, the screenings are only validated for those that you're looking for risk. It's hard to find them if they know that that's what they're being, especially in that situation. But they weren't going to change it. They're like, well, we just feel like that's not appropriate, despite knowing that we have these babies with neonatal abstinence syndrome. So I got them to change based on finding the one piece of data that they knew they couldn't argue with. So I looked at everybody who they had ordered a test on. And what I found is it was overtly racist. I found that 17% of our population is African American, 22% of the population of our babies born are African American, but 88% of those that were urine drug screened for anything in the hospital were African American. It's racist. I mean, period. And then when you get to bring that up with the CEO and talk about how that would look really funny in the newspaper if that ever happened to get out, then they automatically start to do it. So you play the game, and you play it mean sometimes. I mean, we have a job to do, and we have people we have to treat. And so, you know, tell them to read a book. I mean, I'm just kind of at that point. I've done this for so long now that, you know, I'm like, I don't know what to say. I mean, we have science this deep that says for a subset of the population, this is what we need to do. And if you do it well, they get great outcomes, and they do, and they're happy. And so having that conversation is, what do you want for your patient? It's always the same thing you want, right? But sometimes you have to find that hook. You have to find that, show me your outcomes. And you ask them that. Show me your 30, 60, 90-day, 1-year outcomes. Make them show you outcomes. And they won't have them. Because if they had them, it would freak them out if they followed that. And so you have to go after some of those things. Or just find a different place to deliver treatment or put them in-house. I mean, we've had to do that as well. People are right to their opinion. I just don't like it when their opinion abuts science and doesn't, you know, and we pay for it. So those are things that get frustrating.